problem. My name is Adrienne Shippers. I'm the manager for the clinical documentation program. Many of you probably encountered Brian Green, who works closely with cardiology and CTSU as well, doing documentation. We used to be located here in the facility, but since we no longer actually physically touch the patients, they've put us up at the tower. So the communication for us is mainly through via email and phone right now. We're trying to work on that. So essentially, let me put this into slide view.
It's the thumb.
Thank you. Barely like a regular mouse much on this. Okay, so that's me. So I left this fairly loose for today, only for the fact that I wasn't sure what Laura was going to present as well. We do have two very different functions. We have two very different coding teams that use this record, and my department uses this record under quality improvement in the Center for Clinical Excellence. So I'm not located with billing and coding and HIM, health information. All right, so objectives today are just an overview of what our clinical documentation program is, why it matters, how the record gets coded, what makes a diagnosis codable. Diagnosis examples, we'll talk a little bit about audits, and this is where you're basically protecting yourself and making a defensible diagnosis, and best practice. All right, so our clinical documentation program was implemented in January of 2008. They had done a retrospective audit of probably 10,000 records and found that we were not only leaving money on the table, but our patients looked like our patients at Northwest Hospital. So all of the doctors went, but wait a minute, our patients are sicker than that. And all the nurses went, no way. So what it came down to was the coded record. And this is inpatient facility coding. This doesn't have to do with specific provider coding or billing. Okay? So there's 8 of us. We're all nurses. We've got a variety of acute care experience. I've been here since 1993. I've mainly worked with transplant. I was the RN3 up on 4 Southeast for many, many years. And we have developed this robust process for diagnosis capture. We found what was lacking in the medical record, and how we wanted to fix that was through query and clarification via email of our attendings. And so we're not currently using mid-level providers. We just this year rolled out a program where we are now sending clarifications to our mid-levels. So that's you guys. So we'll go over that a little bit too.
I don't think that the power is on. Oh, it is.
Can I leave it up? All right, so we review inpatient records for incomplete or conflicting documentation, either something that can or cannot be coded correctly or be able to maximize the record. And we'll discuss the impact of that. So the impact first. University Health System Consortium is our benchmarking. That's who we take all of our data and compare ourselves to. It's 147 other academic hospitals that are aligned in this consortium, and our coded record is the description of our patient, and it matches against the coded records of other facilities. We also review for patient safety indicators, and if you're not familiar with the term, just let me know, because I don't know what your familiarity is at this point. But those are things like your accidental puncture and lac, your postoperative sepsis, any of those measures that would profile against us or actually matter to our quality. Hospital-acquired conditions is different than that, but that's your CAUTI and your CLABSI, VAP, those sort of things. We also review for those specifically, because sometimes we document them and it's not accurate. It's a supposed or it's a rule-out diagnosis, but once it's documented, it's codable in inpatient facility coding. We also review the records for length of stay. Was the stay longer than the expected? We review the records for risk of mortality models, so we actually compare our patients to other patients at other facilities to say, our patient has this many diagnoses, their risk of mortality just went from 10% expected walking through the door to 70%, and how does that look against other hospitals? We also compare ourselves on cost of care models. All of the coded record matters to hospital profiling, and all of the coded record matters to the physician profiling. And then final, what we do is, our impact is case mix index, and that's CMI, and then that matters to reimbursement. When we send out our clarifications to our physicians, only 8% of what we send out actually matters to reimbursement. However, we affect every other part in there. So when people equate us with coding and billing, we actually more times than not sometimes make a negative impact to the record just by getting the record accurate. Okay. So I will say that last year my team of 8, and actually we were down about 1.5, we reviewed 10,480 records and we sent 4,700 clarifications. So pretty busy, pretty in that record. So how does our inpatient record get coded? So I know that Laura was talking about, you know, the record goes to the coders. That's a different set of coders. There's actually different coders for the provider billing than there is for inpatient facility billing. So the patient appears on a work queue of inpatient coding team when the patient is discharged. The moment that patient is discharged, they populate the queue of that coder. Coder assigns a primary and secondary diagnosis from that encounter only. So when I say encounter, I mean that admission, that whole admission. When Laura was saying encounter, she just meant that day. Okay. Coders have set guidelines that direct them in assigning a diagnosis code to the record. And then after they finish coding out that record, if it's something that our team has reviewed, they'll actually communicate to us whether or not they agree or disagree with us, because we also assign codes for that record and then do a comparison at the end of it. The coded record is then released to inpatient charge capture to bill the insurance. And from there, that coded record also gets released to the UWP, so separate, and that would be Laura's department. And the coded record is also submitted to UHC, that's the University Health System Consortium, and then they're the ones that disseminate all of the information out to the profiling bodies. The coder has 3 days to complete the coding of most of these cases. So if the coder is waiting on an OR report or a discharge summary, they may be under pressure because a lot of the cases that you deal with are called high dollar. They may be under pressure to release that record. And if there was something that was going to show up in the discharge summary that was going to tie everything up in a bow or rule out something, they would not have that documentation. So they would just be coding to the documentation that they have available to them. They only code within the encounter. So if you have something that is a clinic note that you think is important or supportive, they're not going to code to that. Okay, so if there's 2 days ago the patient was in clinic, that's not going to get pulled in, so it's up to you to pull in that information. Rules of coding. The primary diagnosis is the condition which is determined to drive the admission, and most of the coders take this from that HPI statement. So what drove the patient in through the doors, either from the ED or as a planned admission or as a transfer from an outside hospital. And transfers from outside hospitals are a little trickier because you usually have more than one system that the patient is now coming to be evaluated for, or more than one thing going on. You can have a patient coming from an outside hospital with sepsis but needing a workup for an LVAD. So if 2 conditions both meet the guidelines for primary diagnosis, then the condition with the higher reimbursement may be assigned. And in this climate of financial instability, that's very appropriate. And we've decided as a facility that that's the way that we'll direct it. So there are sometimes that we have our attending surgeons say, oh, but they were admitted for heart failure. And we'll say, yes, but they were also admitted with sepsis. And we treated both equally on admission, and so therefore we're going to capture the sepsis. Secondary diagnoses, and this is where we start getting into the gray areas of your documentation and the assessment and plan. For a secondary diagnosis to be codable, it must meet one of the following guidelines. So it either has to have something that has required clinical evaluation, therapeutic treatment, diagnostic procedure, extended length of stay, so you can say that the patient had an postoperative ileus that required an extra day in the hospital, or atelectasis requiring an extra day, or increased nursing care and or monitoring. That's actually documented by you, not by the nurses. Nurses can they can only code from 2 things from nurses, and that's a BMI and a pressure ulcer stage. Past that, it's the providers. And chronic disease is considered reportable even if it does not require evaluation or treatment, because that always impacts your risk of mortality and morbidities. Any questions? It's pretty basic. All right, and why is this important? Because we are also audited. And our big one is the RAC audits, and I don't know if you guys know what RAC is. It's the Recovery Audit Contractor. It was only supposed to be a time-limited audit where Medicare went out and was trying to figure out how much money could they recover based on hospitals that might have been upcharging. They recovered so much money that it is now a implemented department, never to go away. We also have commercial audits, and that'd be like your Aetna Regents Blue Shield. And then quality audits are just for that purpose, so that we can make sure that we're not overcharging, undercharging, upcoding, downcoding. Most auditors consist of coding and medical professionals who are paid on commission of the recovered accounts or amounts. That's a wee bit of a conflict of interest. It pains me to say that when physicians do that, I'm suspect. So you want to prevent insurance denials through improved documentation. And it's just within this last year that I've actually started assisting our compliance and our coding department with insurance denials. And it's actually been quite an eye-opener on what they'll deny us on. Some of it's just plain old goofy. All right, target diagnoses for denial then are AKI, acute blood loss anemia, and that's probably because we turned it into a diagnosis 7 years ago and now it's like candy. Electrolyte imbalances, hyponatremia, and hypokalemia are reimbursable diagnoses, and they should be. They're sepsis, malnutrition, respiratory failure. This is a new one for me. Patent foramen ovale is targeted right now by the auditors, and shock. And so we're going to use what we call 360 documentation to support diagnosis, and really it's to support the resources used. Anytime any of my team sees something in the clinical record that is utilizing resources or is clinically significant and doesn't have a diagnosis attached to it or something that we can capture in a diagnostic statement, we will clarify for it.
So are those targeted because those aren't specific enough, just like shock?
They're targeted because they're documented so often that most the auditors have decided that these are their go-to diagnoses to just deny. So acute and sepsis being the number one, and we have the number one. We are number one in sepsis in basically all of UHC, but also Washington State, and we should be. I mean, that's what we treat here. These are easy for the auditors to deny, and if any of these show up as the only diagnoses that cause positive reimbursement, that's what they're going to go after. And since these are so common to most of our patients, this is the easiest thing for them to go after.
So it doesn't mean we shouldn't use any of them?
No. If anything, it just means that we need to make sure that we have support in the record for each diagnosis. So when Laura was talking about having support for the diagnosis that you're treating and documenting the work that you do and the resources, sure, she's more extensive than what I'm actually looking for. So I'm going to show you what the abridged version is, and then you can add in her requirements as well, or UWP's requirements. All right, so 360 documentation, it addresses signs and symptoms along with the plan for treatment. And usually what we look at when we're looking at the record is there risk factors for what this patient has going on? Were there clinical indicators? Was there treatment? And can we support it with guidelines if available? So my group is very big on the evidence-based practice, and we really are trying to attach guidelines to most of the clarifications that we send. Some of them don't have them. Some of them are just, over years, this is what we've started to call it. But we're getting better at it. And so I'm going to give you some examples, okay, because these are things that you frequently see. So CHF. CHF requires the following specificity to be coded we can code unspecified CHF, but it doesn't mean anything. It doesn't impact any of the risk models. It doesn't impact your reimbursement, and it looks like it's a history code. So if you're actively treating CHF, you want to note whether or not systolic, diastolic are combined, and whether or not it's acute, chronic, or acute on chronic. And so what I would see is just a systems charting, and it would just say CHF, acute on chronic systolic heart failure, list out your EF, continuing Lasix, continue home cardiac meds. That is all that we need for inpatient facility. That will support the documentation or the diagnosis because it shows active management of it. If this was cut and paste every single day, then that might be a problem. You cannot code high ejection heart failure. It does not code to diastolic. You actually have to specify diastolic. So it's just one little takeaway on that. This will not change in ICD-10. This will remain the same. The only time that we know that we cannot ask for some type of heart failure specificity is if it's valvular, and we won't even go there. But if they have a combined heart failure that's valvular and related to some sort of cardiomyopathy or something, then we try to get the specificity. This is a big one for you guys, and that's the cardiorenal syndrome. Cardiorenal syndrome is a very broad diagnosis, and in ICD-10, especially going forward, it only codes to CKD, and it codes to a CKD that's unspecified. But we know that cardiorenal syndrome can also be acute. So we're looking at the type 1, 2, and 3 really for cardiorenal syndrome. So if you have cardiorenal syndrome and it's a CKD, then you need to document it as CKD. If you have it as either an AKI or an ATN related, then we need to document it as AKI or ATN due to cardiorenal syndrome. And so here's just some examples of that. This would be perfectly acceptable in the record for the inpatient facility documentation requirements. So under GU, AKI, creatinine increased 0.3, and here's where I'm saying why you would list your guidelines. There are two different guidelines that are out there for AKI, and that's RIFLE and that's KDIGO also, which is a combination of AKIN and RIFLE. RIFLE is very stringent, and I checked with Dr. Musinski, and she actually says that KDIGO is very appropriate for most of our patients. Otherwise, we're undercoding and underdiagnosing AKI, which in the cardiac population has a really high rate of mortality and morbidity, or morbidity and mortality, whichever happens first. So it would be perfectly acceptable to say AKI, creatinine increase 0.3, which is KDIGO criteria. Monitor creatinine urine output, limit fluid bolus due to heart failure, because gold standard treatment for AKI is fluid bolus, but you can't really do that in your patient population, and avoid nephrotoxics. There's an ATN one. One of the frequent things that I get back from audits is they will actually say ATN is coded, however, patient was still making urine. Fine. Non-oliguric ATN then, due to CRS, and here's your BUN to creatinine ratio that. I know that you can't use a FENA. You can use a UA, but usually after 3 days after initial injury, ATN is not going to show up on a UA. So that's typically what we'll use. Continue fully monitor urine output, avoid nephrotoxics. And then if it really is just chronic, and that's the underlying disorder, CKD stage 3, secondary to CRS. Questions? All right, so acute blood loss anemia, my favorite. So technically a decrease in hematocrit related to blood loss requiring treatment. Monitoring is considered treatment. You do not have to transfuse to be able to diagnose this, but it should be greater than the standard ordered lab. So if you're just monitoring because you're doing a daily CBC, then it doesn't sound like it's a very significant diagnosis, and we probably shouldn't be capturing it. So yes, good documentation would be heme, acute blood loss anemia due to GI bleed. Most patients are on Coumadin, 34 down to 26. Repeat hematocrit INR, treat if hematocrit less than 25. No. Heme, hematocrit 26, GI bleed, daily CBCs. The coders cannot infer or assume any sort of diagnosis. It has to be specifically spelled out. The other one to watch here is that I know that I've seen acute blood loss anemia come out with very minimal surgical EBL. And so if it is acute blood loss due to ongoing blood loss like drains or something like that, if you just document that in there, that will support it. All right, sepsis. So sepsis is very positive for or highly targeted RAC audit. And we are now moving into the Surviving Sepsis campaign, which there's going to be a lot of hubbub and literature coming out to the services. It starts in the emergency room. Sepsis is defined as infection and 2+ SIRS criteria. So that is the new definition of sepsis, and that is actually going to be the reportable definition of sepsis, and that is by the CMS June of 2014, their latest brief that they came out with, because we are going to be reporting all severe sepsis and septic shock to CMS.
So you have to have a documented infection? It can't just be a...
You can have a probable or suspected infection because it almost always starts off that way. And for a lot of the patients, especially if they're immunosuppressed, if they still end up being culture negative, you can always we treated them for what's suspected culture negative infection or culture negative due to immunosuppression, broad coverage, suspected. And that has to show up though on the discharge summary. Anytime we do suspected, probable, likely, or possible, that has to show up on the discharge summary, that language. Okay. So documented is suspected, probable, possible sepsis. You can rule out sepsis if it's appropriate. The patient came in with what we thought was sepsis, but after a while, we took on the temperature to the lymphoma and the heart rate to dehydration, so they've been ruled out. But you need to rule that out. You can't just stop documenting it. Because if it says that they've been treated for sepsis and it wasn't noted as suspected, probable, possible, or likely, the coder can code it, and they will. Document the causative organism if it's known. Just because it appears on the laboratory culture data does not mean that the coder can code it, and that actually, depending on what the organism is, it actually raises their risk of mortality.
It's also nice if you document that you don't know what the causative organism, because then it shows that you've looked.
Yep. Still pending cultures, some way to state that you've looked at that. Document any related organ dysfunction, and this would be organ dysfunction that's actually related to the sepsis. So if you have somebody that's developing AKI, encephalopathy, something like that, due to the septic state that they're in, you want to actually say that SIRS plus this, or sepsis plus this. And urosepsis is not a word. It cannot be coded. So urosepsis in I-9 goes straight to UTI. Sepsis isn't even a thought in the thought process there. Urosepsis literally has no code in ICD-10. So we have to ask for sepsis due to urinary tract infection. Okay. So perfectly appropriate for us is ID, sepsis. There's your clinical indicators. There's your possible source, Klebsiella line drive infection, IV antibiotics, APAP, ID consult. Yep.
I noticed that you're putting in the system for every diagnosis.
So if when we're talking about how to do the assessment and plan and what the best documentation looks like for that, we've seen two different things, and neither of them is wrong for inpatient facility billing. And it's either documenting by problem or it's documenting by system.
And we're doing problem-based.
We're doing problem?
Yeah, we're doing problem.
So if you're going to do problem-based, then you're going to head it with sepsis.
Right.
Correct. Okay. Good to know. Thank you. So we'll talk a little bit about problem-based. I think the only thing that I want you guys to be careful of on problem-based is noting acute respiratory failure as a possible problem, but using it literally as a heading area. There's a lot of variability on acute respiratory failure, and we'll get to that. But so you just changed it to sepsis and explained the rest of it. Malnutrition. I actually have a 25 slide set on malnutrition that I did for the nutrition team themselves. So this is a difficult diagnosis. It is incredibly important to risk of mortality models almost across the board everywhere. It's also important to reimbursement. When we first started in 2007, only one patient was documented with malnutrition out of all of our patients, only one for the year of 2007. We are now up to, after doing a lot of education with our providers, about 6% of our population has been documented and captured with malnutrition. And that's actually higher than the standard that's actually out there right now, even though we know that per literature support, about 20 to 30% of all patients that come to us have malnutrition on some level. We have two types of malnutrition, and we use these two diagnoses only: protein calorie malnutrition and severe protein calorie malnutrition. That's just what our nutrition team has been taught and what they've learned. There are other diagnoses out there. You can also describe a patient as cachectic, but these are the ones that actually get coded and reported. And they follow the Aspen criteria, and that's something else I'll go into in a minute. So documentation tips for this is going to be to review the RD's note. They actually have the clinical criteria in there for their diagnosis. They will call out what type of malnutrition it is based on what either the weight loss is or the length of stay or the length of time that the patient has had a decreased PO intake, whether or not there's muscle or fat wasting. WDWN is not appropriate just because the patient is obese or fluid overloaded, and that's pretty common to see in documentation. So try to refrain from that, because a lot of our patients are, while they might be heavy set, that well-nourished component really bites us in the butt.
What is that WT?
Well-developed, well-nourished.
Oh.
You know. Document limited treatment rationale. Not all treatment, so if you have somebody that has severe protein calorie malnutrition, let's say they've had a greater than 15% weight loss in the last month, they've got those little teeny itty bitty chicken arms, they've got temporal wasting, but it's not appropriate due to their goals of care to actually insert a feeding tube, put a PICC line in them for whatever reason, then you need to document that yes, they do have this condition, but we're not providing aggressive treatment because it's not in alignment with their goals of care. Or maybe, we're so cautious on any fluid administration into them right now, there's no way we can add even that, 500 cc's of enteral feeding. And please do not order albumin or prealbumins. There's no gold standard for malnutrition labs. Okay? So this one then, instead of FEN, you could use severe protein calorie malnutrition, SPCM, or you could use protein calorie malnutrition if they're just like a mild or moderate malnourished state. And so you would say that what their weight loss is, muscle wasting, nutrition consult was, diet is tolerated due to goals of care. And some of this should be reflected up in your physical exam. So if you have temporal wasting, if you have loss of muscle, if you have muscle wasting, if they look thin, cachectic, that sort of thing, if they have hair loss due to malnutrition, any one of those things, put that up in your physical exam, it supports this diagnosis. Respiratory failure, again, another favorite. So these are the indicators that we use for clarifying for the diagnosis. It's usually pretty obvious when somebody has respiratory failure, but your borderline patients are those patients that are requiring 5 to 6 liters of nasal cannula, but they just can't really move because every time they do, they become acutely dyspneic, right? They are technically in respiratory failure. So the gold standard for us is pulse ox less than 90% on room air. We do make sure that we're not overreaching on that one, or less than 95% on 2 liters. Okay? Does not need to be based on ABGs. You can document your physical findings, including tripoding, short sentences, respiratory rates, accessory muscle use. Document any increased O2 needs, especially if they're increasing and decreasing each day. Document what that was when you went in and saw them. And document chronic respiratory failure if they're using continuous home O2 for greater than 3 months. And it's not just for comfort. So for this, you'd say either acute respiratory failure or, if appropriate, acute on chronic respiratory failure, requiring 6 liters nasal cannula, secondary CHF, limited activity tolerance, and then there's your plan. Shock. Shock by itself without further specificity, especially in ICD-10, has very minimal impact to mortality and morbidity for us. Once it's specified for some reason, it becomes a different shock and it has more impact. So specify it as hemorrhagic, septic, cardiogenic, or vasoplegic. So for cardiac, this cardiogenic shock has been a hot button for most of the cardiologists and the surgeons. And some are very liberal on the use of shock, and some are very conservative. And a lot of it is based on INTERMACS. So the criteria that we've now currently using is if a patient is INTERMACS 3 in the hospital, then they are considered to be in cardiogenic shock. So for this patient, it would be cardiogenic shock, just demonstrate the cardiac index and their severely decreased activity tolerance. One of the physicians actually said he went from walking a mile a day and now can't even walk around the unit. That's cardiogenic shock because we're showing that he's not perfusing. Mild confusion, so treatments, dobutamine, LVAD workup, whatever it might look like. If you have any question of whether or not you should diagnose cardiogenic shock, either ask the attending because a lot of them are specific on it, or leave it just as hypotension and we will follow up on it. Or you can contact me or Brian and that information will be at the end. Chronic reportable diseases, I had said earlier that chronic diseases are reportable whether or not they are treated or evaluated during the encounter being the admission. So, and those include, and these all have ties to risk of mortality, Your chronic anemia, chronic thrombocytopenia, diabetes, please document any associated disorders. Heart failure, chronic arrhythmias, COPD, obesity, and BMI, congenital disorders, states of paralysis, so wheelchair dependent, using a lift to mobilize. We get a whole lot of descriptors, but just either call them tetra, quadriplegia, paraplegic.
So you want these documented like in our assessment?
Yep, or even if this is in a problem list, it doesn't need to be readdressed down below.
Okay.
Right, because these are, if it's still a chronic anemia, just as, put it in the problem list as chronic anemia. And we will code to it based on the fact that it's a chronic issue. If their hematocrit's 37 though,
If you think it affects people's decision-making, like if they have diabetes or if they have, something, if they're wearing a CPAP at night, I would include it down in your assessment and
Okay.
plan. If it doesn't have any impact on what we're doing for them or our decision-making, then I wouldn't.
if let's say if they have diabetes with neuropathy, and it's not important to whatever care you're providing, even though you probably have some sort of diabetic management in there, right? But let's just say for whatever reason it's not. If it's on the admission in the past medical history, it'll get coded from there, okay? Because that's recognized then as a problem unless they had a pancreas transplant that's not going to go away.
And I also think you should always put in your psych illnesses in the assessment and plan, just because when they go a little delirious or whatever, we can
It's right
remember
there.
it's right there, and it's a daily reminder if it pops up that, oh, right.
Yep, and those should always be addressed because really those patients, as good as they are, it also explains some of their ability to really retain their own information. It bumps up their reimbursement as well on some of the payers. If you happen to know the specificity though of the psych illness, so if it's a major depressive disorder, if it's bipolar type 1, type 2, if it's, if the schizophrenia has any sort of manic association or any of that, if you can get that in there, that specificity really helps. It's not required, but it definitely helps. There are places where that information is used. Okay, so 360 documentation don'ts is don't use symbols, like the directional arrows, which you guys don't.
What do you mean?
So like if
leading
you were to write
to,
like,
and I put the little greater
no,
than sign?
like, that's not even right, is it?
Oh, I see.
Increased sodium, yeah.
Can we do like crit 34?
Down to,
forward
yeah,
arrow?
that you can do, as long as you
Okay.
have a diagnosis with that. Because,
right,
yeah,
okay.
so if you've got a diagnosis of anemia, ketoacinemia, any of those ones, then that's fine. Use of high or low, like high potassium doesn't mean anything. It can be high normal. So if you're actually treating hyperkalemia or the patient is outside of that high normal range, then call it hyperkalemia because that's the actual diagnosis. And I know that, especially with hyponatremia is a very easy diagnosis for the majority of our patients because they're almost all hyponatremic. And it does matter to their risk of mortality. However, some people don't think that they shouldn't be documenting hyponatremia unless they're actually specifically treating it or monitoring it. And so if you're looking at the daily lab values just to evaluate where their sodium level is, you can put in hyponatremia. Okay, or mild hyponatremia. Because many times hyponatremia does not need treatment.
So where do we do that? I mean, if we think the hyponatremia is related to the heart failure, would we call it out as a whole separate diagnosis?
Yeah, hyponatremia related to heart failure.
I know, but we've already got like acute on chronic, decompensated, systolic heart failure, impella in place, diuresing, hyponatremic, where would
So-
we actually look at that as a separate problem?
We would look at it as a separate problem.
Okay.
Yep. All right, so instead of using lab values like INR 1.7, if the patient is not coagulopathic due to Coumadin, then you would use the language coagulopathy INR 1.7 just to demonstrate what it is. Okay. And I know it saves a lot of time, so if the need is to cut and paste because truly the person that documented before you or you documented the day before, then it's okay, but you have to make those changes to reflect that you actually visualize the patient. Okay. All right, so these are the do's. The do's is a lot longer. So you want to maintain an accurate problem list, and the problem list is always a problem, especially if you're taking in this patient from another provider or another service. Sometimes that problem list, no kidding you, is 27 problems deep, and none of them were yours. That is being worked on. However, if you see something that blatantly is not appropriate for that patient, it is actually your responsibility to go in and resolve or cancel out that problem, okay? Document by system or diagnosis. We prefer systems, but it sounds like you guys are going to do diagnosis, so that's fine, as long as everybody's on the same page. Support the diagnosis with the assessment or the plan of care. And so with the assessment, I mean that physical exam. So if you have something down below that's demonstrating acute respiratory failure or some sort of heart failure, you want to see that the patient either has some sort of 2+ edema or crackles or increased work of breathing up above. Okay. Support the diagnosis with guidelines if known. Update your physical exam. You need to rule in and rule out your diagnoses. So if you're looking at a sepsis diagnosis and you come to it and it's not a diagnosis that's appropriate for the patient, then you're going to say sepsis is ruled out. Okay. If on discharge summary you've not still been able to rule out sepsis, you just leave it as sepsis was not ruled out.
Do diagnoses that have been resolved or like ruled out, should we make them fall off of our notes, or do we carry those forward?
So I've seen two things, and here's my answer on it. If a diagnosis is suspected, possible, probable, likely, somehow that diagnosis needs to make it, and it was treated, somehow that diagnosis needs to make it to the discharge summary.
Mm-hmm.
So if the best practice for you guys is to continue a list down below of resolved diagnoses, which is what some of the teams do, then that's where you would capture that. Okay. The other thing to do with that is, when you do your problems and diagnoses and put them on so that they'll populate the discharge summary. Do you guys use that function? Where you enter in a problem or a diagnosis and it gives you either the SNOMED or the, okay. So there is a section that you go to enter in your diagnoses that you say this is a discharge diagnosis, so that if you're doing 3 days worth of notes and you come on and do the discharge summary, the diagnoses that you were working on automatically populate the discharge problem list.
Okay.
If you have a diagnosis that was ruled out, you should put it on that as well, because then it will just automatically populate that discharge summary. Document diagnosis as resolved when they're resolved. And document present on admission status. You do not have to document present on admission status on admission. If 4 days later you decide that you've come up with the diagnosis for what they presented with, we can get that as present on admission. But if you notice that you've been treating hypokalemia for 4 days and we finally write it on day 4, but nobody's written it the whole time, you can say on day 4, hypokalemia, present on admission, and it is okay it'll get coded as present on admission. Those present on admission assignments are incredibly important when we're trying to do risk mortality adjustment as what did the patient look like coming through the door. Not what happened to them during their stay, but how do we compare them to other patients coming through the door. Okay? Document probable, possible, likely diagnosis, and document diagnosis on both the interim and the discharge summary. All the diagnoses that were important to that patient's care during that encounter, and that encounter is the whole admission. Okay, so Brian Green is technically your documentation specialist and your contact, and that's his information up there. He is traversing the Grand Canyon right now, so I am here, and that's my information as well. So you can see that Laura and I have very different purviews and functions for how we use the record and what the record gets used for. But are there any questions? And I could do hours on single diagnoses, so I don't want to put too much on the plate.
Can you send me your talk, please?
Absolutely.
Thank you.
Yeah.
That was great. So with ICD-10 coming on, will this, I got this diagnosis information directly from a card you guys previously had created.
Yep.
And so I just wondered how much that will change.
How much is that gonna change? So
I mean,
the-
aside from requesting people use laterality and more
Right.
specificity.
So very little of that card is gonna change. The only thing that will change, in arrhythmias, a fib now gets to have greater specificity, and that's the chronic paroxysmal persistent and whatever the
Loan.
lung,
Loan.
loan, loan
Means
AFib.
like,
Just time limited, right?
yeah.
Yeah, so there's that one, but everything else really, and laterality is specific for procedures mainly, and paraplegias. So unless you're doing procedure documentation, you're okay there. Heart failure is going to remain the same. The AKIs are going to remain the same. Respiratory failure needs to be determined as hypercapnic or hypoxemic. I'm trying to go down my systems here. Anything gut really remains the same. Yeah, there's not a lot of changes for actual diagnosis. I mean, we could do greater specificity of anemia, but then you'd have 23 options to pick from, and we're just not gonna do that to y'all today.
Why aren't they changing the heart failure to half ref or half PEF?
Why aren't we?
Yeah.
Because not the whole nation uses it. So the code sets are determined, number one, internationally, and then number two, by our nation. And so they look to see what the language is across the nation. So like AKI, that for years we couldn't code and had to ask for acute renal failure, even though the nephrologists had been using AKI for years, but it meant injury. And so injury you could only get by blunt force per coding. So this is one of those things that's a process, and we've actually petitioned them to allow that to equal it, but it's probably going to take 5 years after we do our initial petition. So it does come down to, preserved heart failure is regional, and unless there's enough regions, they don't change the set. So we went from a code set of about 60,000 diagnoses to a code set of 120,000 diagnoses, and then we increased our code set on procedures from about 25,000 procedures to almost 70,000 procedures that are able to be coded. Yeah, and it's a little crazy. The procedure coding is, specific to America. So that all has to do with mainly reimbursement, because there is no other country that does that. Next question?
Do you have any more cards?
I do. Actually, I don't have them with me, but I can send them to you by inter-office.
That'd be great.
Yeah, Brian's got a whole set of them.
Great.
And then as ICD-10 sugars out, we're creating a bit more of an expansive card so that we can really give identifiers for encephalopathy and what that means, the difference between delirium and encephalopathy.
Okay.
We'll give you the CKD staging, I'll give you the Rifle criteria versus the KDIGO criteria, that sort of thing. But we want to wait for ICD-10 to come out first because they keep changing codes on us right now. And so I don't want to give you specificity if it's going to change in 3 months.
When do we start using ICD?
ICD-10 is a go live October 1st. Yeah. Coding team's been working really hard at that. And so far, the documentation for inpatient facility has been right on par. So we've been doing really well. With the exception of some teams that really exceptionally chart. And by exceptionally, I mean only by exception. Very limited.
Okay.
Yeah.
Sounds bad.
Yeah. Yeah, that exceptional wasn't a good thing.